All right. Hi, everybody. Good morning. My name is Joshua Mann, and I'm the Director of Engagement and Outreach for the VHL Alliance. I'm excited to welcome you to our first VHL CCC Spotlight session. Every month, we will be highlighting a medical professional at one of the VHL clinical care centers. To start us off, I'm pleased to welcome Dr. Russell Lonser. Dr. Lonser is a professor and chair of the Department of Neurological Surgery at The Ohio State University Wexner Medical Center. He earned his MD from Loma Linda University and received his neurosurgical training at the University of Utah. During his residency, he completed a research fellowship in the surgical neurology branch at the National Institutes of Health. Upon completion of his residency, he joined the staff of the surgical neurology branch at the NIH and became chief of the surgical neurology branch in 2007, where he started the NIH Neurological Surgery Residency Training Program before moving to Ohio State in 2012. Dr. Lonser previously served as the head of the research subcommittee in the Head, Neck, and Spine Injury Committee for the National Football League and on the editorial boards of Neurosurgery, World Neurosurgery, Journal of Neurosurgery, PLOS1, and Science Reports. He is currently a consulting editor for neurosurgery clinics in North America. He has authored over 300 publications and won numerous awards. Dr. Lonser is the sponsoring physician of the VHL Clinical Care Center at Ohio State University and serves on the VHL Alliance Clinical Advisory Council. We are extremely grateful that he could take this time this morning to talk to us. Thank you, Dr. Lonser.
Josh, thanks a lot. It's great to be talking with you.
Welcome. So why don't you tell us a little bit about yourself and about the Clinical Care Center at Ohio State?
Yeah, so as you mentioned, that very kind introduction, I've been at Ohio State now just over 7 years. Prior to that, I was at the NIH for over 12 years, and most of my focus was in von Hippel-Lindau disease and other tumor-related syndromes during my time there, as it remains here. And we formed a comprehensive center a few years ago to provide comprehensive care across the spectrum of VHL. And I know all of you and the group there, as well as many of the patients, understand the importance of that broad-based kind of multi-specialty interaction between neurosurgeons, endocrine surgeons, medical oncologists, radiologists, urologists, and on and on and on. That coordinated care and serial monitoring is critical. We have it here. We have it as all the other VHL Alliance centers have.
Thanks. So your specialty is neurosurgery. So I was wondering if you could talk to us a little bit about VHL in the central nervous system.
Yeah, I'd be glad to. So as you and the VHL patients know, there's two tumors that occur in the nervous system with von Hippel-Lindau disease. One of them is endolymphatic sac tumors, or we call them ALS TS for short. The other is hemangioblastomas of the cerebellum, brainstem, and spinal cord. Both are benign tumors. And I'll just talk briefly about the endolymphatic sac tumors. These tumors occur in VHL on the order of anywhere between 9 and 13% of patients. Interestingly enough, they're some of the earliest presenting tumors symptomatically. The symptoms they can cause, because they arise in what's called the vestibular aqueduct of the inner ear, so your hearing apparatus, is most commonly hearing loss, and it can be sudden, meaning occurring within less than a day, or gradual, and that occurs in far less frequently. The sudden occurs in about 75 to 80% of patients, and then the more gradual is 25 to 20% of patients. We often can image them, but in a not insignificant portion of those tumors, we rely on symptoms, and we can do some very sophisticated imaging, special images with MRI as well as CT to detect them. The treatment is important because it's different for endolymphatic sac tumors than hemangioblastomas, which I'll get to in a second. In endolymphatic sac tumors, once we see them, whether you're symptomatic or not, we recommend surgery because we don't want anybody to lose hearing. Other symptoms include ringing of the ear, a feeling of fullness, and very rarely you can get pain in the ear. Those are the most common forms of signs and symptoms related to it. And it's something we keep a very close eye on because we want to operate as soon as possible to prevent permanent problems that can occur later on with those. What we call the cranial-spinal hemangioblastomas are the most common tumor in von Hippel-Lindau disease, including renal or the other forms or other types of tumors associated with VHL. It's been estimated 80 to 90% of VHL patients will develop a hemangioblastoma. Those that do, greater than 90% will have multiple hemangioblastomas. And these occur at a really conserved anatomic distribution. They occur, 99% either occur in the cerebellum, brainstem, or spinal cord. 40% occur in the cerebellum, another 40% occur in the spinal cord, and 5 to 10% occur in the brainstem, and another 5% in the nerve roots called the cauda equina, the lower nerve roots of the spinal cord. These, again, are benign tumors. They're made of what we call the tumor cell, blood cells, and another form of blood cell called a mast cell, and as well as vessel cells, endothelial cells, all of which, again, are benign. We've studied these in depth through natural history studies when I was at NIH. And for a number of years, we followed over 3,000 of these tumors. These tumors grow in what we call a saltatory pattern, meaning they grow for a while, they'll stop growing, and they'll grow again. So what we found in those cases is that we don't want to operate based on growth or changes, edema, or even cyst formation. We operate when the patient has very early symptoms, because we don't want to wait too long so that the symptoms become fixed. We want to operate on symptoms that are very mild in nature and just starting, so that we can get those tumors out. Because if we operated on growth alone, we realized that we would, over a span of 10 years, we would be doing on average, 4 unnecessary surgeries if we just looked at imaging. So it's real important to focus on early symptoms, get those tumors managed when that happens. The treatment of choice is surgery till this day. It's still the gold standard at this point. The potential morbidity or complications associated with that are low in experienced hands. It ranges anywhere between 4 to 8%, where someone, comes, let's say, perfectly normal, except for maybe some sensory changes or some pain, and they may have some weakness or something afterwards. That's in a very narrow subset of patients where that will occur. And so those are the two tumors kind of in a nutshell. The difference, obviously, is really the indications for surgery. Endolymphatic sac tumors is remove them when you find them. Hemangioblastomas only remove them when they become symptomatic. One of the other critical features we learned with that natural history study was that as you get older, after the age of 40, the likelihood of a patient developing new tumors goes down significantly. So if we can minimize the number of surgeries early in life with the hemangioblastomas, we can maintain normal function throughout a patient's life and provide, and that's ultimately our goal in doing that. So.
Thanks, Dr. Lonser. So we've had a few people submit questions in advance. So if it's okay with you, maybe we'll go through some of these questions. And a reminder for anybody who's watching live, you could type questions into the box, and we will try to get to as many as we can. So the first question is, what are the different surgical options depending on location of tumor, whether it's in the brain or spine or somewhere in between?
Yeah, so the difference in options are really the approach. Now, when you look at spinal cord tumors, for example, over 95% of spinal cord tumors occur on the posterior or the backside of the spinal cord. 2/3 of those will originate within the sensory, what we call the dorsal root entry zone. So the approach in the spine, in the overwhelming number of cases, is from the backside of the spine, which is great. It's the easiest way to access. We can still maintain spine stability by removing the bone over the tumor without having to replace it. The other places can occur is in the cerebellum. Most of those do occur on the posterior aspect of the cerebellum. So we go through a posterior approach on the patient's back, or the back of the neck, or on their back, is where we enter from. But the surgery itself is identical. No matter where it's located, we use a microscope. We circumferentially go around the tumor and devascularize it very selectively, and you can remove it with minimal blood loss, and no matter where it's located.
Thanks. I know you mentioned that that surgery really is the gold standard still, but I wanted to know your thoughts, or some people ask questions about using stereotactic radiation surgery as an option, or SRS.
Yeah, that's a great question. We get asked this frequently. When Ed Oldfield was, he and I worked together for over 20 years, and in the late 90s, stereotactic radiosurgery was being used at the NIH, as well as a number of centers. There was a significant group of patients with von Hippel-Lindau disease that were treated with cerebellar and brainstem hemangioblastomas. We studied those patients. They were treated at a number of leading centers. We followed them prospectively. We wrote a paper on 20 of these patients that had 40 tumors that were treated. And what we found was, during the first 5 years, the control rates were exceptional, in the 90 to 95% range. But as time went along, the rate of control, meaning the tumors started to grow again, the ones that were treated, started to approach what we would see in the natural history of the disease, meaning we didn't really change the natural history of the disease from a progression standpoint at about 7 to 10 years out. So saying that, we still use surgery in the overwhelming number of patients because it can be done safely, it's effective, we can remove the entirety of the tumor without recurrence. We use stereotactic radiosurgery in a very small number of cases where we can't, the patient, for medical reasons, can't undergo surgery, or the location is deemed too risky in the case of removing it. That's exceptionally rare, though. I think patients, the other caveat to that, patients with cyst or edema should probably avoid stereotactic radiation surgery, because it opens up the vessels, the permeable vessels around the tumor, and more fluid can leak out, creating more swelling or even bigger cyst growth, and can require long-term steroids and things like that to manage. So we use it in a very select group of patients. Question though.
Now, talking about treatment options, I know a hot topic lately in the VHL community is possible drug treatments, and as you know, there's a trial now going on, PT2977. Do you think that drugs like this might be an option in the future?
Absolutely, and that's the ultimate goal, is to stop having to do surgery on any tumors related to VHL. And I think, the science, Josh and I were talking earlier about Bill Kalin, who's really been a pioneer in the science around HIF and the downstream effects of the VHL protein and mutated protein in the case of von Hippel-Lindau disease. With all these exciting developments, I am optimistic and positive we will, hopefully in the near future, have drugs that can stop the growth of these tumors or cause them to go away. And because I think all of us, particularly as surgeons, envision a day where we won't be operating on VHL, and it will be a pill or some other form that's not invasive to treat all of the tumors.
Well, we could only hope, right? So we're getting some questions in from the live audience. Somebody just asked the question, what about Avastin?
Yeah, so Avastin has been looked at a number of years ago. It seemed to be very promising. It's used, at least in our experience, it's used much less frequently. Avastin, there's some, what it can do in some of the VEGF inhibitors way back, and Bill Kalin was part of it, Stefan Richard was part of these studies in the late 90s. What they found was these Avastin and these other types of medications that decreased the permeability, the leakiness of the tumor vessels. What it did was created some opportunity for symptomatic improvement because the swelling, meaning the edema or the cyst, would stop growing because they weren't leaking fluid. But the problem was that didn't actually impact the size of the tumor. And many of these, like Avastin, these other drugs you have to come off of because they can cause kidney or other problems. And then the tumors would grow, and the tumors had been growing at the time, or what was happening was the leakiness around from these vessels in the tumor were creating problems again. So those strategies, for the most part, have not been continued, to be honest with you.
Good to know. Here's a question about the actual surgery itself. If bones or vertebrae are removed from the spine in order to operate on a tumor there, are they replaced, or is there something else put in their place, or are they just permanently removed?
They're permanently removed, and that includes the skull as well. Our group, as well as several other groups, have looked at this. And, you know, the problem with doing what sometimes you could do is put hardware in, titanium screws to instrument the spine to provide more stability. It creates imaging, MRI artifact, which sometimes can, you know, obscure the things you really want to see. So we've avoided doing that. But saying that, several years ago, we looked at cervical spine in patients in von Hippel-Lindau disease that had multiple operations. And we found, when you took x-rays, that they had some signs by not replacing the bone that there was some more laxity or subtle instability of the spine. And a handful of patients had some pain associated with that. Saying that, we never had a clinical circumstance in that cohort of patients where we had to go back and provide instrumentation. It's a possibility. It's a spectacular question because it really gets at the cause of if you had one or more surgeries, are you prone to have some of what we call this instability of the spine? The answer is yes. But in several hundred patients in spinal cord tumors, have never had to infuse anybody.
Thank you. We're getting lots more questions. Here's a question. How often, what is the success percentage rate of gamma knife procedures?
So it goes back to the stereotactic. And that's actually a really good question because stereotactic radiosurgery comes in various forms. They have very similar complication rates and accuracy rates. So in the gamma knife, there's Linac, there's CyberKnife, there's ZAP. Those are the more common forms. They're all stereotactic radiosurgery. And I don't think we've ever been able to, nor would I expect there to be differences in the successful outcomes in the various forms because they're very similar technologies. So I would say this, that they have good control for 3 to 5 years, but then at the 7 to 10 year mark, we start to lose that. These tumors can begin to progress. If you look at our prospective study from several years ago, in that it really didn't provide better control at those more distant time points than if you had not treated them at all. And so that's why we still, gamma knife still falls into that stereotactic radiosurgery. In fact, gamma knife was, I think, the largest form of stereotactic radiosurgery that was used in that study that we published.
Thank you. When does scar tissue stop developing, and what symptoms could scar tissue from previous surgeries cause?
Another great question. So scar tissue starts within days of, it's a natural healing process in and outside of your body. It occurs in the brain and the spine. In the spine, sometimes you can get that scarring fusing the back of the spine to the dura or the outer lining around the spine. We sometimes call that tethering. And very, very rarely do we see that become symptomatic. I can tell you in nearly 20 years, I may have operated on tethering less than 5 times out of several hundred von Hippel-Lindau disease spinal cord patients that I've operated on. And so you rarely see it. It is a possibility. There's ways, we think that we can avoid it by very careful microsurgical dissection around the tumor, minimizing any blood that can get into the cerebrospinal fluid, because that blood is irritating. And we think that the inflammation can cause scarring. So it's just really as bloodless as possible, removing these tumors.
Now, what are the actual symptoms that people should be looking for from hemangioblastomas in the brain and spine that might necessitate surgery?
Yeah, another great question. So let's start with the cerebellum. Headache is not uncommon. Clumsiness with fine motor movements, particularly of the hands, is not uncommon as well, or feet. Sometimes with if there's a lot of tumor, which is, now that we know how to serially screen and things like that, we don't see those scenarios at all, or very infrequently. You can have some swallowing difficulties or speech, kind of enunciation issues, but just really fine motor control and headache are probably the more common symptoms of the cerebellum. Brainstem, sensory issues, because it's in the back of the brainstem. Over 70% to 80% occur in the area called the obex, which is a very defined part of the brainstem on the back. And we've seen primarily sensory issues associated with that. If they get bigger and aren't removed, you can see some swallowing problems. We've seen hiccuping. We've seen anorexia, actually. Patients, because of the vagal stimulation near that area, patients feel full all the time. And we've seen people actually, and it tends to be in the teen years, they tend to look, and then once we remove that tumor, they can put on 20 to 50 pounds over a span of 6 months. We've reported this. We've reported a case where a 16-year-old patient at the time always felt full, wasn't eating, didn't progress through puberty because of malnutrition. So that's rare, but something that can occur in the teen years. Hiccuping, coughing, swallowing difficulties, and sensory changes. Spinal cord pain, kind of back pain is the most common, and then sensory changes, because 96% or more of these are in the back of the cord. Most of them are in the sensory entrance areas, the dorsal root entry zone. So sensation, numbness, kind of lack of good, clear sensation is a big problem, as you would expect anatomically.
So here's a question. Can multiple brain surgeries interfere with CSF absorption that might require a shunt?
Great question. We've looked at this in detail over several hundred patients. There's controversial or differing opinions out there. There's been groups in Europe and Asia that have advocated after one surgery placing a shunt. We never routinely prophylactically place shunts with surgeries. The vast majority of our patients have not required such shunting with a range of 1 to 13 surgeries. And this is several hundred surgeries or tumors we've removed over several hundred patients. We have not seen the need to do that. It's very, very infrequent in our experience, less than 5%.
Wow. How often do you use an angiogram or embolization prior to surgery on the cerebellum? And if you had a bleed from that previously, does that eliminate future use of that treatment?
Yeah, another great question. The last time I've ever done an angiogram, no matter where the tumor was well over a decade ago. I think with, the VHL surgeons that have a lot of experience with this don't require it. I have only used embolization once, and that was for a very different scenario where a VHL patient had a 6-centimeter tumor in the sacrum, and we could easily take the feeding vessels, which were large, that were coming off the big leg arteries, the iliac arteries, and we were able to embolize those. I've never used embolization in any other case, because I do believe there's not a huge but not an insignificant risk with embolization. I also rarely use angiograms, as I mentioned before. I could count on maybe one hand out of, it's less than 0.5% of the time. And like I said, I haven't used one in over a decade and a half. Just not found them useful, to be honest with you.
Wow, thank you. So we have just about a time for 2 more short questions. Here's a question. Can a hemangioblastoma that has already been removed appear in the same place in the neck or head?
Well, so yes, they can. It's one of 2 things have happened in that scenario. One is there was probably a very small tumor in that region, that was adjacent or nearby. If you do see that, most of the other scenarios where the tumor wasn't completely removed in the first situation. But there's really two. It's possible. A third would be that a new one popped up. But as we were talking about before, new tumors do arise, and it's on average one tumor every 2 years in the range from 20 to 40 years of age, and then it gets much smaller after that. So the likelihood of the very same spot's low. I think there's either there was a second tumor there that was very tiny and was not removed, or the first tumor wasn't completely removed.
Thank you. And then one final question, Dr. Lonser. What's the best method for testing for ELSTs? And I know that they're notoriously difficult to spot on scans, but what can people do to make sure that they're being thorough?
Yeah, that's a spectacular question. And these are complex, as you said, Josh. So high resolution, thin cut studies using an MRI through the temporal bones, because the tumor really sits in the temporal bone part of the hearing apparatus, and high resolution, thin cut CTs of the temporal bone. And because what we're looking for two different things with those images. On the CT, we're looking for very subtle signs of erosion in a tumor that's not very clear. On the MRI, we're looking for subtle signs of enhancement on a tumor that's not obvious, that's sitting in the region called the vestibular aqueduct. And we did a study with Alex Vortmeyer a number of years ago in these very small tumors. We found that they actually probably don't arise in the endolymphatic sac. It's really the vestibular aqueduct which attaches the endolymphatic sac to the inner ear apparatus. And if we have a patient, though, that doesn't have any imaging evidence on CT or MRI, and that's not a small proportion of ELST patients, that has hearing loss or some other symptom, what we call tinnitus or ringing in the ears or fullness or those things in a VHL patient. There's other studies that can be done where they give gadolinium and they do delayed scans, and you can see what we call the endolymphatic hydrops, which is one of the things that underlies the symptoms in an ELST. And we've published a paper on a handful of patients without any imaging evidence of an ELST, where we saw evidence of hydrops on MR, and we found a tumor in each of those patients. So, but those can be very complex patients. So with a VHL patient, we are always, with any type of hearing or audio vestibular problems, dizziness, vertigo, because vertigo, ear ringing, and hearing loss are the three most common symptoms that can be confused with Meniere's. But in the context of VHL, we're really looking to find an ELST in those cases.
Thank you. Do we have time? One last question?
Sure.
So the question is, if a patient knows that they have tumors in their spine, one nearing close to 1 centimeter, and they feel tingling in their toes, but something that's manageable, not too detrimental to their life, is that something? What should they look forward to? What should they be looking out for? When's the right time to make a move?
So if that tumor was in an area that would cause tingling to the toes potentially, we would recommend surgery. It's not an emergency. On the other hand, we don't want to wait months or longer, because here's the reason. This is a wonderful question, because what we did know when we studied the patients that we operate on in brainstem and spinal cord is, once the symptoms occurred and became more and more noticeable, we couldn't reverse them, except in a very small percentage, 7% of cases, where we could take that tingling away at some level. But most of the time, our expectation is to have those patients be exactly the way they were when they came in. And so if someone had tingling in their toes and I saw them, and the tumor could be attributed to that based on the location in the spinal cord, we would definitely recommend having that tumor removed.
Dr. Lonser, thank you so much for being here with us and for everything you do for the VHL community. We really are very appreciative for you taking the time this morning. For everybody who's watching online, I want to invite you to learn more about the VHL Clinical Care Center at Ohio State University, of which Dr. Lonser is the sponsoring physician. You can learn more at vhl.org/OSU. Again, that's vhl.org/OSU. And again, Dr. Lonser, thank you so much for being here.
Josh, thank you so much for having me. This is wonderful. And the VHL Alliance is absolutely, as everyone knows on this, is spectacular. And, you know, again, all the patients that have been so receptive to helping us better understand the disease. Can't thank all of you enough. So thanks again. This has been great.
Thanks. Have a good day. And for everybody watching, this will be recorded and posted in the next few weeks. So thank you and have a good weekend.
Thanks. Thanks, Josh. Thank you. Thanks, everybody. We'll see you.
Bye-bye.
Bye.